All right. Hello, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Previtt. I am one of the MMOA faculty, Modern Management of the Older Adult. We are the geriatric curriculum through the Institute of Clinical Excellence, and we have 3 courses in our online curriculum for certification MMOA. This is the day that we start actually our next cohort of Modern Management of the Older Adult Essential Foundations. We still have a couple seats left, I think less than 10. So if you're interested or you want to jump into this cohort, do not wait on it. We are going to have so much fun going into the fall with this new cohort. So if you're interested, just let me know. If you have any questions, let me know. All right, so right now we are working on just doing a bit of an update of the literature when it comes to some of the material that we present through the Modern Management curriculum. And one of them that has grown immensely in popularity over the last several years is high intensity interval training. So this is not a new concept. This is not a new type of cardio. Obviously, CrossFit is a methodology that kind of utilizes parts of HIIT training. So for athletic populations, younger populations, this is something that's been utilized for a really long time. Where it is becoming more and more popular is being used in older adults, including individuals in their 80s and 90s, and then working on what is the clinical applicability of using HIIT training for individuals who have different types of pathophysiologies or medical complexities, and how do we start incorporating some of this into our practice. So first, when we're thinking about high intensity interval training, this is a type of aerobic training where we are alternating back and forth from periods of high RPE 9 out of 10 or 10 out of 10. Sometimes we can go 8. So let's say 8 to 10 out of 10 with alternating windows of lower intensity training. So that can be RPE 4 or 5 out of 10 or complete rest. So you're working out a really high intensity, you're going back. When it comes to clinical guidelines across all age categories, when we're looking at aerobic training, the general recommendation is to accumulate in a given week 150 minutes of moderate intensity training or 75 minutes of vigorous intensity training, ideally done in a window of at least 10 minutes of intentional exercise at a time. And this is true for older adults and individuals with different types of chronic disease. So obviously, vigorous intensity or HIIT training can be a time-saving methodology to get in all the good health benefits of aerobic training to our system in obviously less time. But the question happens in clinical practice, especially with our older adults, is can my older adults handle this? Is this something that is safe for them, given some of their medical complexities? And if you listen to nothing else from this podcast, the answer is an overwhelming yes. We just have to make sure that we are using our skilled care to recognize what type of prescription we are going to utilize with high intensity training. And I'm going to go through that a little bit in this podcast. So firstly, we have to look at some of the physiology and the reason why high intensity interval training has been shown to be highlighted in clinical practice so much more. The first thing from just an administrative perspective is that we get a lot more work done in a shorter amount of time. And sometimes we don't have a ton of time with our clients. So it can really create efficiencies and optimize the time spent with our older adults. Especially when we're going into higher intensities, these are the situations and circumstances where supervision may be more required. I don't need to sit and watch a person do 20 minutes on a bike. That is not skilled care. That is not what is going to be the biggest bang for my buck when I only have 30 minutes with my patient. So I would rather push into high intensity training, make sure that they have the dose that I'm looking for. I'm monitoring them appropriately. Vitals are vital and watching their effort and exertions. That's more my skill care, and that's going to be a better use of my time. So that's kind of just like administratively. From a physiology perspective, what we see is that in comparison to moderate intensity training, HIIT training has similar effects on ventricular function. Our heart is a muscle. So when our heart is damaged or we're trying to rehab a muscle, all of the same things that we are thinking about with musculoskeletal rehab are applicable to pulmonary rehabilitation, right? So we want to be thinking that we are applying progressive overload to our patients with respect to, stress and adaptation. And by pushing into high intensity thresholds, we can create that stress and stimulus to drive adaptation and improve the efficiency and function of the heart, especially for individuals with cardiopulmonary compromise. So we have similar effects on cardiac function. We're going to see similar improvements in less amount of time. We have larger improvements in VO2 peak in HIIT training versus moderate intensity continuous training. And we're seeing greater improvements in some of our functional outcome measures. So that, especially as, there's all these threats for reimbursement based on changes in some of our outcome measures, knowing that we're going to see bigger improvements in our outcome measures like the timed up and go and the 6-minute walk test is a good justification for why we are biasing towards high intensity training over moderate intensity continuous training. And so with the larger improvement in VO2 peak, it kind of makes sense why this is true, right? We talk about in modern management how it's so important for us to be applying high load, low volume exercise prescription to our older adults whose goal is to get stronger, because we know that as more external load is applied to a person's skeleton that we have to move against gravity, we're going to see this ramping up in recruitment, which is going to refine motor unit efficiency and increase motor unit collateral sprouting. And it's also going to get our higher type 2 fibers, our more energy intensive fibers, to be scaling up in terms of our recruitment strategy so that we don't have this use it or lose it for those type 2 fast reactive fibers in those higher thresholds of motor unit recruitment. So this is going to be true potentially in the heart as well, to think about it that way, right? If we are working at our heart at 50% all of the time and we never push into 80%, then it's expensive to keep all of that tissue and those muscular fibers, all of those things that are allowing us to hit those thresholds. So it makes sense that we're going to see larger improvements in VO2 peak, and we're seeing all of these good changes in our cardiac adaptation with respect to HIIT training. The last one that we're seeing in the literature that's really interesting and is going to kind of go into our conversations around pathology is that we also see superior cerebral perfusion with HIIT training versus moderate continuous training. And this is why we have started to see a push for HIIT training with respect to especially subacute stroke rehabilitation. And it's because if we can get more oxygen and all of those good nutrients to our brain and have all of that perfusion happen to the brain, then we can potentially promote accelerated healing or more healing than we could potentially with other types of interventions. And so that's really been starting to be explored in the research. And it's really a really exciting area of practice. And so when it comes to HIIT training for the older adults, well, when it comes to any type of rehabilitation intervention for older adults, we're going to look at healthy community dwelling older adults first. And then we're going to start inching into pathology. And so this is what has started to happen over the last several years, which is super exciting, right? So stroke rehab, with our studies on healthy community dwelling older adults, seeing this metric of superior cerebral perfusion, then we have the justification, okay, well, then maybe we should be evaluating this in individuals who are recovering from a stroke and see if we can see benefits from using HIIT training versus moderate intensity continuous training. And we are starting to see some of that preliminary data come out showing superior outcomes for individuals with stroke using a HIIT protocol compared to even moderate intensity continuous training. So I'm going to start naming off some pathologies that we now have evidence to support the safety, feasibility, and effectiveness of HIIT training in their rehabilitation protocols. All right, coronary artery disease and hypertension, stroke, obesity, individuals in their 80s and 90s, individuals with congestive heart failure, those that have sarcopenia or clinical levels of muscular weakness, individuals with chronic obstructive pulmonary disease, individuals with lung cancer going through active treatment, and individuals with multimorbidity. This is based on me doing a recent review of the literature with high intensity interval training and pushing into some of these pathologies. And so it's really wonderful to put our mind at ease as clinicians, that we now have a lot of research that supports the use of HIIT training across a variety of different chronic diseases and pathologies. And if we start really taking a step back and critically thinking, it makes a lot of sense. Let's take the pulmonary system, right? You would never think, okay, when I first came out in practice, if you told me that I should be doing interval training with somebody with constructive or chronic obstructive pulmonary disease, I would have said, oh my goodness, you're joking, right? But it makes sense, right? Because we know that individuals with COPD have impaired gas exchange and they have weakness of those respiratory muscles. So if we get individuals working at higher intensities, and intensity is relative, we're obviously going to be monitoring their vitals. We're going to be looking at their oxygen levels. Then we could potentially stress the respiratory muscles enough that we can drive adaptation to make it more efficient and allow for more efficient gas exchange. And this is what the literature is starting to show as well. So it's just starting to really come on board with what we're seeing, that even with individuals with multimorbidity, a large amount of, burden from these chronic disease accumulations, they're still seeing this benefit, and the conservative management of using HIIT training is still going to be applicable in these types of clinical scenarios. And so the question now becomes, okay, so we know that from a physiological perspective, we're going to drive better adaptations with HIIT training. We now have research across a variety of different complex chronic diseases in that they can be useful for rehabilitation, prevention, so in that secondary, tertiary prevention space. And then now the question becomes okay, well, how do we implement this? What do we do? And there's a variety of different ways for us to do that. So when it comes to looking at the interval and we start to ask, what is the best interval? The answer is it doesn't really exist, right? This is where our critical thinking comes in. This is where our skilled care comes in, because we have evidence for, 10-second intervals to 4-minute intervals. We have had protocols that look at a 0.5 times rest versus a 3-time multiplier of rest. And so the answer is it depends on the client that you're working with, but I want to give you guideposts. So we have this large capacity, or this large amount of variability that we can use for programming. And so when it comes to our prescription, our individuals who have higher chronic disease burden, lower exercise tolerance, and lower physical function, we're going to be taking a shorter work interval and a longer rest interval. And that rest interval is likely going to be complete seated rest. As our clients continue to improve, one way for us to look at progressive overload and increase in aerobic capacity is by seeing the changes that we're able to make, either by increasing the work interval and keeping the rest interval constant, or flipping that and keeping the work interval constant and bringing the rest interval down, or changing the rest interval from seated rest to something that's lower intensity. And so again, this gives us this chance for us to see quantifiable changes in a person's capacity that we can use to justify the effectiveness of our intervention. And then we're thinking about HIIT, oftentimes we're thinking about strictly aerobic types of modalities. That could be walking, running, new step, rower, like whatever, dancing intervals, whatever that looks like for your client, whatever they enjoy. But we can also start putting in that intensity with our resistance training, right? So this is where things like high intensity resistance training intervals are starting to come into the literature too. And this is a whole other podcast episode, but we start thinking about things like CrossFit for older adults, and that really is interval training with resistance exercise. And so we can utilize that as well. This is where things like the every minute on the minute, or every 90 seconds, or the Tabata 10 seconds or 20 seconds on, 10 seconds of rest, or whatever interval you want to use, utilizing AMRAP sets. You're going to get a push towards an increase in cardiovascular demand, but you're also going to be strengthening the musculoskeletal system. And so you're getting, again, that efficiency of your interventions to allow to drive adaptations in the cardiac system as well as in the musculoskeletal system. And so really exciting things that are starting to come up to give us as clinicians comfort that these things have been shown to be safe and effective. We know how to monitor. That is our skilled care. We know how to take vitals. We know how to be monitoring the effectiveness of exercise. We know how to prescribe exercise. And we know what the underlying medical filters are that might contribute to yellow or red flags or do not pass goes when it comes to pushing into intensity. This is where supervision is required. This is where we are going to get the biggest bang for our buck. We're going to drive adaptation. We're going to improve our rehabilitation outcomes, and our older adults are going to thank us for it. So if you're looking for some what's the word that I'm trying to use? Some comfort or some me giving you permission maybe to be pushing into high intensities for even with our clients who have pretty significant chronic diseases or medical histories. That's me giving that to you today. So that's kind of what I got for you all today. HIIT training works. We can use it with a variety of our older adults, and we have evidence now for even individuals in lung cancer treatment, multimorbidity, sarcopenia, congestive heart failure, COPD. We got the goods. We got the research. So we're just going to keep exploring what some of these optimal dosages are and continue to implement them with our clients. All right, that's it for me today. I'm sorry that I had to go on a little bit earlier. I'm actually on another interview as soon as I log off here. So if you are interested in learning more about some of the research coming out in HIIT, then I encourage you to sign up for MMOA Digest. It is our bi-weekly email that goes out that looks at research that's coming up in the Jerry space specifically. And it comes out every Friday, second Friday morning. So if you're interested, go to ptonice.com/resources. Also, last chance to get into our fall cohort of MMOA Essential Foundations. And if you're on the road, I will see you all. I'm in Julie and Alex are in Montana this weekend, and I am in South Carolina in Greenville the week after that. So we are on the road with MMOA, and we can't wait to speak with you all there. All right. Have a great week, everyone, and I'll talk to you all soon.